Hi, and welcome to Session 7 of the Public Health Surveillance course. This session is focused on public health surveillance in resource-limited settings. While we did talk briefly about vital registration in resource-limited settings, you now know that there are many other important types of surveillance other than surveillance for mortality and deaths. So we have a lecture dedicated to this topic in the course because conducting surveillance can be more challenging when resources are severely constrained, leaving us with fewer tools and approaches to work with. So I'll start by providing some background and context, and then we'll cover 3 examples of public health surveillance being conducted in resource-limited settings. The data on this slide and the next few slides come again from the Global Burden of Disease project at the Institute for Health Metrics and Evaluation. This slide shows the distribution of years of life lost, or YLLs, per 100,000 population by country to give you a sense of where much of the world's premature mortality is occurring. YLLs are calculated for all deaths in a given year and basically sums the difference between standard life expectancy at the age of death minus the actual age of deaths for all deaths in a given setting. So this slide shows only those countries with a lower sociodemographic index, or SDI. The SDI combines information on the economy, education, and fertility rate of countries. So it's not just the income level of the country. And this index, it turns out, is closely linked to health outcomes. In these low SDI settings, the majority of years of life lost per 100,000 are due to infectious causes, shown here in red. And this slide shows how the leading causes of years of life lost have changed in low SDI countries or low SDI settings from 1990 on the left to 2019 on the right. Again, we see the communicable diseases represented among the top causes of YLLs, but also causes like cardiovascular diseases and neoplasms are beginning to play a greater role in more recent years. This could be due to a number of factors, but some important reasons include the aging of the population and improved control of major communicable diseases in low SDI settings. From a public health perspective, we're really very much concerned not only with the causes of death, but the risk factors that are driving those deaths, since risk factors are often the focus of public health programming as well as prevention efforts. And this slide shows those same years of life lost as previous slides, but this time broken out by the risk factors that are contributing to those years of life lost. Looking at it this way, it's possible to see the leading risk factors for YLLs in low-income countries that are things like, it's easy to see that they're things like malnutrition, air pollution, water sanitation and hygiene or WASH, high blood pressure, dietary risks, tobacco, unsafe sex, and among other things. So if we wanted to prevent the most years of life lost through public health efforts in low SDI settings, these would be the risk factors that we would be wanting to focus on. Public health surveillance is as important in low-income settings as it is in high-income settings, and for the most part, for many of the same reasons listed here on this slide. It's especially critical to understand the burden of diseases or major causes of morbidity and mortality, which is the first step of the public health process in any setting. But it's especially important in low-income settings because the resources available for treatment, control, and prevention are usually exceedingly scarce when compared with developed countries or resource-rich settings, where it turns out they're also scarce, but just not as scarce. So as such, it's especially important to have surveillance data that can help decision makers target these scarce resources that are available in an evidence-informed manner because there's just so little to go around. So using surveillance to help invest these resources wisely can lead to substantial gains in life expectancy because people in low-income countries often bear a greater burden of disease and premature death. This is a list of surveillance data sources that you've already seen, and it includes some of the usual sources of data for public health surveillance, things like vital registration and notifiable disease or condition reporting from providers and labs, hospital discharge data, medical claims data, and examination surveys such as NHANES and behavior and risk factor services, programmatic surveillance data, and sentinel surveillance data. We've come to rely on all of these in resource-rich settings. But in resource-limited settings, many or most of these data sources really don't exist, generally leaving us with a much more limited set of tools and data sources to conduct public health surveillance. As you might expect, many of the issues that need to be considered when planning and conducting surveillance in resource-limited settings are somewhat different than the considerations in resource-rich settings. But these considerations in resource-limited settings include the limited and often non-functional healthcare system and the associated lack of infrastructure, a limited number of healthcare providers and laboratories, and in this context this happens in the context of very high need and demand for services, and often an emphasis on treating acute diseases and injuries, and not so much of an emphasis on chronic diseases that require routine medical care and follow-up and longitudinal record keeping for ongoing care over a long period of time, and of course other potential obstacles to developing surveillance systems. Just to provide a little context, this shows a typical primary healthcare facility in rural Mozambique, and you can appreciate both the lack of infrastructure as well as the overwhelming demand and need for services. There's a waiting line spilling outside of the clinic here, and primary healthcare facilities are the lowest tier in the formal healthcare system, and they're also where most people receive their care, or at least where they initially seek care and other health-related services. Indeed, many healthcare systems in low-income settings can be so under-resourced and infrastructure can be so lacking that it's next to impossible, for example, to use some tried and true public health surveillance approaches that rely on healthcare providers and laboratories to report notifiable conditions or events to a central entity in a timely manner. And in most instances, the public health infrastructure and capacity beyond the healthcare system to actually receive, process, and disseminate surveillance data as information is also equally limited. We've seen examples of how health departments in the US, such as the New York City Health Department, use surveillance data, including administrative data, to characterize the burden of disease and to monitor the health status of populations. Sometimes you see these examples down to a very granular geographic level, such as the neighborhood level. For example, in this New York City Community Health Profile report, it gives a list of the top 10 causes of death and the top 10 causes of hospitalizations for adults in central Brooklyn. And we can see how these outcomes in central Brooklyn compare to New York City as a whole with regard to the rankings. And this kind of information is really useful for setting public health priorities, especially because it gets down to lower geographic levels. It's not the national level or the state level or even the city level or the borough level. It's even lower than that. This kind of information is essential to help develop what is often a risk factor focused public health agenda with priorities such as those that we've seen in the Take Care New York initiative that the City Health Department embarked on years ago. The priorities of this initiative, informed, of course, by surveillance data, helped focus the public health efforts where both the need and the potential for impact were the greatest. So the challenge for public health surveillance in low-income settings is how to get a Take Care New York type approach in places like Lagos, Nairobi, and Mumbai, or in very rural areas where there's usually no vital registration, often having a highly limited healthcare infrastructure, limited public health human resource capacity. National, regional, state, and local public health information systems usually don't exist to receive and process information and data. And there's often not much in the way of useful administrative data, such as the hospital discharge data or medical claims data that we rely heavily on here in the US. How is it then public health surveillance is typically conducted in resource-limited settings? Well, some typical strategies include periodic surveys, such as household surveys or sentinel surveillance sites, disease or program-specific case reporting, laboratory-based surveillance, and sample area vital registration with verbal autopsy, to name a few. Some challenges, though, working in resource-limited settings include the often vertical or siloed nature of the public health programs and systems, such as the TB program or the malaria program. These are not usually integrated with each other or with other parts of the healthcare system or public health system. They don't necessarily share the same or similar information systems either. And they often depend on external donors from outside the country who sort of drive the health agenda by offering funding and supplying funding for very specific things, but not for others. So there are also, though, some opportunities for public health surveillance in low-income settings, such as the more leveraging of technology, mobile phones, and the internet. Increasingly, we see schools of public health that are beginning to launch in many low-income settings, and there are vertical or siloed health programs in resource-limited settings, but these can also have the potential, with a little planning and investment, to strengthen the broader health systems and infrastructure. So it's possible that, done well, investment in these large vertical programs could have an impact on other disease areas as well. So that kind of sets the stage a little bit, and we'll next talk about 3 specific examples of public health surveillance approaches in low-income settings, all from sub-Saharan Africa. And these approaches that will cover our household surveys, sentinel surveillance, and surveillance as part of a disease eradication program. We briefly covered demographic and health surveys, or DHS surveys, in an earlier session. And as a reminder, these are nationally representative household surveys that provide data on a wide range of topics, but are focused on the areas of demography, health, and nutrition. Demographic and health surveys have been conducted in 84 countries, and they're usually conducted about every 5 years, which is kind of a long interval for things that are rapidly changing. Sometimes there are interim demographic and health surveys in between these larger 5-year surveys. National DHS surveys are typically funded by the U.S. Agency for International Development, as well as the host countries and other partners. We're going to delve into the 2022 Kenya Demographic and Health Survey, or KDHS, which was their 7th to be carried out in Kenya, and it followed similar surveys that were conducted in 1989, 93, 98, 2003, 2008, and 2014. So they're spaced about 5 years apart, sometimes a little more. The survey's objective was to provide up-to-date information on socioeconomic, demographic, nutrition, and health indicators for planning, monitoring, and evaluation of various health programs and policies. And data collection took place from the month of February to July of 2022. So you can see here with the data were disseminated in this report 1 year after the close of data collection. The 2022 Kenya DHS was a representative sample of about 42,000 households, and the sampling design allowed for separate estimates for key indicators in each of Kenya's 47 counties, as well as estimating demographic and health indicators for both urban and rural areas separately. The participants were adults in each household, women aged 15 to 49 years, and men aged 15 to 54 years. But there were questions included about household members of all ages. From this table, you can get a sense of the household sample and the response rates broken out by urban versus rural settings. Of about 42,000 households that were selected, 38,700 were occupied, and nearly 98% of those households had an occupant who ended up completing an interview. The response rates were very high for both urban and rural settings. And of the roughly 22,000 households that were selected for completion of full questionnaires, 20,000 were occupied at the time of the survey, and the overall household response rate was 94.8%. And of the eligible women and men in the household who were selected for interviews, the response rate was very high for women at 94.8%, and was lower, but still quite good for men at 87.3%. On the right, you can see a map of the 47 county geographic units, and the sample size in each of these counties was adequate for producing county-specific estimates of key DHS indicators. So what are the main areas of focus of the 2022 Kenya DHS? In addition to information on the respondent's background and characteristics, the DHS survey captures information across many different realms, including fertility levels and contraceptive prevalence, of mortality, childhood mortality, maternal and child health. Just going quickly down the list here, children's nutrition, knowledge and behavior related to HIV transmission and other sexually transmitted diseases, non-communicable diseases and other health issues. It doesn't say here, but it also gathers information on risk factors like smoking and alcohol use. And of course, through the household interview, the interviewers ask respondents to enumerate all of the individuals who live in the household, along with their age and gender, even though those other household members are not necessarily the ones being interviewed. And when you do this, it allows the construction of a national population pyramid, which you've seen before, and it shows the age and sex distribution of the entire population of all ages. And so through the Demographic and Health Survey, it's possible to construct an estimate of the population period for the entire country in 2022. And on the next few slides, I'll give us just a sample of some of the information generated from the other data collected in this survey. By asking respondents in the household about deaths due to road traffic incidents in the 12 months prior to the survey, as well as severe injuries due to road traffic incidents, it's possible to estimate the national death rate and burden of injuries per 100,000 population. And this table shows these estimates by urban versus rural residents and also by household wealth quintile. In fact, it shows an almost dose-response relationship with increasing wealth, which perhaps could correlate with things like car ownership or use of cars. In any case, it's possible to get an estimate of the overall burden of road traffic incidents, health that result in death and severe injury. By asking about pregnancies among household members who are 15 to 19 years of age, it becomes possible to estimate the teenage pregnancy rate. And this map shows how it varies by geography. And the graph on the right shows how teenage pregnancy varies by household wealth as well. And it appears to decrease substantially, like maybe threefold, as household wealth increases. Among women aged 15 to 49 who had a live birth in the 2 years prior to the survey measured whether they attended antenatal care at any time during their pregnancy and whether they had 4 or more visits during that pregnancy, and also whether they had a visit during the first trimester of the pregnancy. As assessed in 2022, 98% of women who had a live birth attended antenatal care at least once. 66% had 4 or more antenatal care visits, and 29% had at least one of those visits in the first trimester of pregnancy. Based on the trends, all of these indicators appear to be improving with time. It's also possible to get even more details on the pregnancy and delivery experience, such as whether blood pressure was measured and whether a urine sample was taken as part of the antenatal care services, and also whether the birth took place at home or in a healthcare facility. There have been major improvements in all of these indicators in Kenya over the last few decades. And I also just want to point out that this information is gathered through a combination of checking women's handheld cards that record some of this information, recall from the participant, and also some reviews of actual records in clinics also take place to verify and refine some of these estimates, just to give you a sense. I also mentioned how it's possible to estimate death rates, such as the infant mortality rate or the under 5 mortality rate, by asking participants about deaths among family members in these age groups in the preceding years leading up to the survey or in the current year of the survey. And this slide shows an example of how these data can be used to construct even trends in some of these outcomes. And they're showing improvements over time across the board here. It's also possible to get at the levels of vaccination coverage among young children. Interviewers will try to get this information from the vaccination cards that people hold at home if they're available. Otherwise, they will try to obtain it by maternal recall. This slide shows that 9% of women and 3% of men have been told by a healthcare provider that they had high blood pressure. And of those, 32% were taking medication to control it. There are similar estimates for high blood sugar. The percentages on the left are, of course, likely underestimating the true prevalence of hypertension, for example, since access to care and routine screening for hypertension is still not generally the norm in Kenya. So this likely reflects people who have presented to care with symptoms or those with more severe hypertension, in other words. The Kenya DHS also measures physical violence and related trends more recently by gender. On the right, they also broke down the types of violence experienced, both ever experienced and experienced within the 12 months preceding the survey. Finally, while specimens were collected for biomarker testing in the Kenya DHS, the results weren't available in time for the main report in 2022. But a common biomarker is HIV status, and I include an example here from the 2008 Kenya DHS where they measured it. Through that test, they were able to generate representative estimates of the prevalence of HIV among adults by province and by sex. And you can see how the HIV prevalence varied by province and sex, ranging from 1% in northeastern province to 11 to 16% in the Nyanza province. So you can hopefully appreciate how the demographic and health surveys can be very useful for monitoring population health. Because of the sample size and all the interview data, the result can be examined and stratified. The results can be examined and stratified by age and sex, by geography, and by urban versus rural settings, by education and income. And this helps to identify gaps and areas of need with regard to public health programming. And the fact that these surveys are repeated every 5 years or so, for example, allows the assessment of trends to document the success or failure of some public health programs. The findings of the demographic and health surveys are disseminated through reports that are usually issued quite promptly after the data are analyzed, and you can download the PDFs usually from the government websites or from the DHS website. And finally, they also often make the data available, the line level data, publicly available for people to download and analyze themselves, which can be great for things like master's thesis or capstones. The second example of surveillance strategies that are helpful in resource-limited settings is sentinel surveillance. I mentioned earlier that it's increasingly common for demographic and health surveys, which are nationally representative, to monitor HIV prevalence by incorporating specimen collection for biomarker testing. Well, that wasn't always the case, and it still isn't necessarily the norm. This slide shows a map of the estimated HIV prevalence around the world. Globally, as of 2022, there were an estimated 39 million people living with HIV, and most of them are concentrated in sub-Saharan Africa. Focusing in on sub-Saharan Africa, you can see the four panels below, the prevalence trend, or how it changed over time geographically, becoming increasingly more prevalent from 1984 through 1999. This was a period of time when demographic and health surveys did not routinely measure HIV status or even ask about HIV testing or anything related to HIV. There was also no testing happening in healthcare settings or in community-based settings because treatment wasn't available in the region. And that, among other things, means that it would not be useful to implement HIV case reporting because there was no there were no diagnoses really happening. The burden of HIV/AIDS was too high anyway, with more than 20% of the adult population estimated to be infected in many countries. So you may wonder how the prevalence of health conditions like HIV infection was estimated if the population-based surveys like DHS didn't measure it. The answer in this case is that we use an approach called sentinel surveillance. So what is sentinel surveillance then? Sentinel surveillance is the collection and analysis of data by designated institutions selected for their geographic location or medical specialty and the ability to accurately diagnose and report high-quality data on those conditions of interest. So a sentinel institution or site, such as a district hospital, may be required to report specific conditions, such as bacterial meningitis, in order to quantify the burden of disease and monitor trends. Not all district hospitals in a country would need to be selected to serve as a sentinel surveillance site for it to be useful. A sample of them can work. Ideally, a sample systematically selected from a sampling frame of all district hospitals. But the goal is to get high quality information on the health condition of interest reliably over time from a group of sites. The Sentinel approach is useful for addressing specific and focused epidemiological questions, but because we're not talking about all health facilities, the Sentinel surveillance approach may have limited representativeness or generalizability. The basic idea with Sentinel surveillance is that if you're systematically collecting the same high-quality information repeatedly from one year to the next on the same populations and from the same Sentinel sites, it can be useful for monitoring trends and risk factors. So when can you use Sentinel surveillance? Sentinel surveillance makes sense if you don't need a complete count of every single occurrence of a case. It's also good if the sites that you choose are reasonably representative, and it's even better, as I mentioned, if you have a systematic sample from a frame, like that is a 10% sample or a 3% sample of all of the sites that could potentially be taking part in the surveillance activities for the outcome of interest. Sentinel surveillance also can work if you don't need to follow up on every individual case for some public health purpose. As we've seen, as a part of public health surveillance, sometimes once a case is identified, there needs to be follow-up, such as a TB case, where household members and other contacts would need to be identified and potentially treated for TB. And if the outcome is something where you don't need follow-up on all cases for public health purposes, then Sentinel surveillance could potentially work. Another consideration is whether or not you can adequately capture detailed demographic and epidemiological data that can be linked to the health outcomes or the laboratory outcomes under surveillance. And of course, to get high quality data from the sites, they'll need some kind of incentive and possibly support to participate in the activities. So the example we're going to cover for Sentinel surveillance is Sentinel surveillance for HIV. Sentinel surveillance for HIV has been done by repeated cross-sectional HIV prevalence serosurveys in selected sites and selected population groups. And clinic or health facility-based Sentinel surveillance for HIV has been conducted, for example, at antenatal clinics or ANCs, where pregnant women present for antenatal care. But you could also do Sentinel surveillance for HIV at sexually transmitted infection clinics or tuberculosis clinics. Sentinel surveillance is also routinely conducted in key populations where surveys can be used to estimate HIV prevalence, for example, in sex workers or people who inject drugs or men who have sex with men. So Sentinel surveillance isn't necessarily facility or site-based. It can occur in specific populations that may be more important from a public health standpoint, but that might be hard to monitor the outcome at any institution or site or as part of a representative household survey. Through these Sentinel surveillance approaches, you can monitor trends of HIV infection over time and break it down by person and place. However, it's important to remember that the estimates that come from Sentinel surveillance, since it's not representative, can really only be confidently applied to the selected population and participating sites. The example for HIV Sentinel surveillance comes from Nigeria in West Africa, and it's the 7th largest country in the world with an estimated population of 231 million people. It's a low-income country in terms of its GDP per capita, and it ranks about 146 out of 192 countries whose GDP were ranked on Wikipedia. The country is very ethnically and linguistically diverse, with more than 250 ethnic and linguistic groups. In 2023 in Nigeria, according to the CIA World Factbook, life expectancy at birth was about 62 years, and the annual population growth rate was about 2.5%. The infant mortality rate was 55 per 1,000 live births, and the maternal mortality rate was over 1,000 per 100,000 live births, or about 1% of all live births, resulting in deaths, maternal death. There's also generally a high literacy rate in the country, especially for men. Sentinel HIV serosurveillance, that is, assessing the burden of HIV by testing serum specimens for antibodies to HIV, was conducted routinely in antenatal clinic patients in Nigeria. We're going to cover the example of sentinel surveillance for HIV in antenatal clinics because I happen to be heavily involved in that work a while back. But I do want to highlight in Nigeria, sentinel surveillance, HIV serosurveillance was also conducted in STD clinic patients, TB patients, long-distance truckers, and injecting drug users. But in this example, we're just going to cover antenatal clinics. So in 2001, I was sent by the CDC to work with and support the Ministry of Health to conduct the National Antenatal Clinic HIV Survey, and it was the second time I had ever visited the country. When I got there, I learned the objective of the survey was to estimate the national seroprevalence of both HIV and syphilis among antenatal clinic attendees aged 15 to 49. And in the next few slides, I'll try to convey what I learned, at least, about how the process of conducting rounds of HIV sentinel serosurveillance at antenatal clinics in Nigeria works. These are some of the stages that are part of a national antenatal clinic survey. The whole process takes place very, very rapidly over a period of a few months from August to October of the same year. Importantly, since it's not continuous over the whole year, it has to take place during the same time of year from one round to the next in order to be able to estimate trends reliably. First, the protocol is developed and a sample of antenatal clinic sites from each of the 36 states in the country is selected. In August, the training began for laboratory personnel as well as state and regional study managers. Then all of the necessary materials were dispersed to the sites, such as the laboratory test kits and blood collection vials, as well as the paper registers used to record all of the data and test results. Once the survey begins, routine supervisory visits happen to make sure that all of the protocols are being implemented and followed appropriately. And there are central management committee meetings, regular meetings to check in to make sure that things are proceeding according to plan. Finally, data entry and analysis and report writing needs to be completed by the end of October in order to ensure that the results will be ready for dissemination on December 1st, which is World AIDS Day of each round. So all of this happens over a period of a few months, and this process is very similar to how it was happening in other countries in the region. The standardization of the approach allows comparison of results from one country to the next, and all the country results and prevalence estimates were estimated and reported by World AIDS Day. So also, though, if countries are conducting their ANC surveys at the same time of year, generally it makes the trend estimates, again, more reliable from one survey to the next, both within and across countries. Here's some information about the methodology of the 2001 round of the HIV antenatal clinic sentinel surveillance in Nigeria. Each round is a cross-sectional survey, and the study population includes pregnant women attending antenatal clinic. The study period was from August to October, or about a 9-week period. Women were eligible if they were aged 15 to 49 years, and they had to be there for the first antenatal clinic visit for their current pregnancy. In other words, it's the enrollment visit at an antenatal clinic for that pregnancy that is what is sampled for the surveillance activities. The target sample size for each sentinel site was about 300, and for this survey, there were 85 sites around the country that were selected. On average, there were about 2 from each of the 36 states in Nigeria and the Federal Capital Territory. So that meant an overall targeted sample size of about 25,800 people. This is a picture from the outside of a typical antenatal clinic. In this case, an antenatal clinic in Benin City, Nigeria, that was chosen to participate in sentinel surveillance that year. You can get a sense of the large volume of people waiting to be seen by a healthcare provider on that day. And in addition to providing their usual services during the sentinel surveillance period, this site would also be enrolling every woman who is presenting to the clinic for their first visit in the pregnancy into the surveillance process. The blood that would be drawn as part of the routine antenatal care visit is taken aside after all routine tests were done, and then that patient demographic information is captured on a paper register using an ID instead of a name. And then the HIV syphilis tests are done anonymously for the purposes of sentinel surveillance. So this implies at least two important things. The first is that HIV testing was not done routinely during antenatal care. If it was, we probably wouldn't have needed to do this type of survey. It could be done through reviewing charts, and the HIV test information could be abstracted and compiled and analyzed. But HIV testing was not being done because sadly there was no treatment or prevention made available for people with HIV in most of sub-Saharan Africa in 2001, even though such treatments became widely available in the US in 1995. The second important thing that this implies is that anonymization of testing meant that the results would never be linked to an identity or to an individual. And while this helped protect privacy and prevent people from being stigmatized, which are both very real concerns at the time especially, it also meant that those who were HIV positive would not be informed of their results. And the ethics of this so-called unlinked and anonymous HIV testing for surveillance purposes has since been called into question. Now to show you just to give you a sense of the data, this slide shows the study population of pregnant women attending their first antenatal clinic visit who were represented in HIV sentinel surveillance in that year. Very little information is gathered on the women, but here's the age distribution on the top as well as marital status information that was captured on the bottom. Nearly 75% of women included were age 29 and below, and at least 88% were documented as being married. What did we find in terms of prevalence? Looking across the 80-plus sites that were part of this survey, the HIV seroprevalence estimate was 5.8%, which was slightly higher than the 1999 estimate of 5.4%. Given the large sample size, the precision of the overall estimate was quite good. And there was a range in the HIV seroprevalence across states of Nigeria of 1.8% to 13.5%, suggesting substantial geographic variability. The serologic test that was used for this survey allowed differentiation between the two different types of HIV, and that this was by and large HIV type 1 and 2% estimated prevalence of HIV type 2. And the median prevalence of syphilis was estimated to be 2%. Once the survey was completed for 2001, the results could be placed into the context of the prior antenatal clinic surveys to be able to look at the trend. Nigeria had been conducting antenatal clinic surveillance roughly every other year, and they missed a cycle in 1997. But you can still see that the seroprevalence in pregnant women at sentinel ANC sites was increasing from one year to the next. This slide shows the prevalence estimates by the geopolitical zone where the antenatal clinic sites were located. The range and estimates, the estimates were lowest in the northwest part of the country and highest in the north central area of the country, showing a range of about 3.8% to 8.4%. In terms of the prevalence in urban and rural settings, recall that there were two antenatal clinics selected from among the many antenatal clinics in each state. One had to be an urban site and one had to be a rural site. And this was to allow estimates of the HIV prevalence according to urban versus rural settings. The prevalence estimate was higher for rural settings than urban ones, however, which was an unexpected finding from my standpoint. But we also know, I knew from having visited many of these so-called rural sites, many of them were not in fact true rural, based in true rural settings. So that could be part of what was going on. And the antenatal clinic prevalence estimates were also mapped by state. And you can see here that antenatal clinics from some states had significantly higher prevalence than those from other states. And in some cases, the estimates were more than 10% prevalence in two states and the federal capital territory. But it's important to remember here that there were really only 2 antenatal clinic sites chosen for each state shown here. The map as presented can actually be misleading if you're not clear about what's being displayed. Each state's color is based on the prevalence estimates from those 2 antenatal clinics that participated in each state. But as you might imagine, this map could easily be interpreted as the overall HIV prevalence of each state. While the ANC sentinel population approach for HIV surveillance is often interpreted as being potentially reflective of the burden in the general population of adults, we need to remember the important sentinel surveillance truism that I mentioned earlier, which is the estimates can really only confidently be applied to the sites themselves and the populations sampled. Care must be taken when trying to generalize further. So just because we're an epi elective here, I want to just focus a little bit about this process of generalizability and the potential for bias that might affect estimates from sentinel surveillance, such as antenatal clinic surveillance for HIV. So in doing so, it's helpful to just take a step back and think about who is selected into the sample and who is not selected or represented in the sample. One of the first things that sentinel surveillance population that stands out about the sentinel surveillance population in this example is that it includes only women aged 15 to 49 years of age. The HIV prevalence among men may be very different than that of women, and so generalizing to men may be a problem. And in fact, what we know in generalized HIV epidemics is the HIV prevalence among women tends to be 15 to 30% higher than men. Another selection that happens is that only a small number of antenatal clinics are included of all possible antenatal clinics. And that means that the one selected may not be representative of all antenatal clinics in the state or in the country. Another factor is that pregnant women may be very different from non-pregnant women of the same age with regard to their HIV prevalence. For example, on the one hand, by definition, women with a recent pregnancy, by definition, had unprotected sex recently, and so they may be more likely to have HIV or a sexually transmitted infection. On the other hand, we also know that HIV infection can cause infertility, and that may mean that women infected with HIV may be less likely to be represented in antenatal clinics than in the general population of women, because they're not getting pregnant at the same rate as women without HIV. And yet another selection happens is that antenatal clinic surveillance is focused on pregnant women aged 15 to 49 years who attend antenatal clinic at least once during their pregnancy in a given year. But how well do they represent all pregnant women in Nigeria in a given year? Well, for that, we can turn back to the Demographic and Health Survey, and this is a table from Nigeria's DHS survey around the same time as this antenatal clinic survey, and it asked women aged 15 to 49 how many visits they made to an antenatal clinic during their last pregnancy. And what we see here is that in urban settings, about 15% of women didn't go to antenatal clinic at all for their last pregnancy. And in rural settings, it's quite different. 46% of women didn't attend antenatal clinic during their last pregnancy. So this gets at this point of the ability to really generalize the prevalence estimates from antenatal clinic even to all pregnant women in a given year, because the HIV status of those who attend an antenatal clinic may be different from those who do not, and that is their HIV status may be related to some of the reasons why they would or wouldn't seek or receive antenatal clinic care for a pregnancy. This could explain, for example, some of the urban-rural differences we were seeing in HIV prevalence in that survey. So all of this is just to say that it's really important to consider the potential biases that may influence sentinel surveillance estimates and how these might impact the ability to generalize beyond the sites and the populations in whom the surveillance data are being collected. This slide shows some of the rounds of antenatal clinic sentinel surveillance that were conducted since that round in 2001. And the 2001 round ended up being the peak estimate at 5.8%. And it trended a bit lower through 2010 in antenatal clinics, shown in the box here. But in 2012, Nigeria began including a measurement of HIV status on its household surveys, like the DHS, which are, of course, nationally representative. So you can see how those more recent estimates compare to the last antenatal clinic estimates. And they're not wildly different, but they generally appear to be a bit lower. This could be part of a trend in decreasing HIV prevalence and good agreement between the two methods, but it could also reflect a slight tendency of antenatal clinic surveillance to overestimate the prevalence of HIV in the general population. So the last example I want to present is the example of public health surveillance in the context of a disease eradication program. For this, it's helpful to cover some terminology. There are various goals of public health programs when it comes to disease control or management of a health threat, and we have terms for them all, shown here sort of in order of increasing levels of intensity. The first is disease control, which aims to reduce the disease incidence, prevalence, morbidity, or mortality to a locally acceptable level as a result of deliberate public health efforts. It requires continued intervention measures to maintain the reduction. An example here are the public health efforts that are used to control diarrheal disease that include things like increasing access to clean water, hand washing and hygiene promotion, and vaccination against infections that cause diarrheal disease like rotavirus. Another step of a bit higher intensity is disease elimination. So not necessarily elimination of the infection, but eliminating the disease that the infection causes. So it would mean a reduction to zero of the incidence of a specified disease in a defined geographical area as a result of deliberate public health efforts again. Here also, continued intervention measures are required to keep it reduced. And the example here that you can think of is neonatal tetanus that is controlled, or sort of a disease elimination occurs through maternal immunization, clean birth practices, and health education to improve umbilical cord care. The next higher step after that is elimination not just of the disease, but of the infection. So it's a reduction to zero in the incidence of infection caused by a specific agent in a defined geographical area as a result of deliberate efforts, with continued measures put in place to prevent the reestablishment of transmission of that infection. And an example here includes measles. The next level of intensity is eradication, which is the permanent reduction to zero, not just in a specific geographic area or in a specific country, but in the worldwide incidence of infection caused by a specific agent as a result of deliberate efforts. In this case, once eradication is achieved, intervention measures are no longer needed because the worldwide incidence is zero and the pathogen doesn't exist in nature anymore. The only example of a successful eradication program to date is smallpox. And the last category is extinction, whereby the specific infectious agent no longer exists in nature or in the laboratory. Smallpox, even though it was eradicated, doesn't fit into this category because it does exist in laboratories of the United States government and the Russian government and possibly other governments, other settings. Thus, extinction of smallpox as a result of deliberate efforts has never occurred. So we're focusing on eradication for this part of the talk, and not every disease or pathogen is eradicable. And as you saw in the Alward paper this week, in this week's readings, there are some specific criteria that have been put forth to help determine when a disease or pathogen could be potentially eradicable. And these key criteria include biological and technical feasibility. There has to be some kind of strategy or intervention that can be implemented that can reduce the incidence of infection. And related to that is the life cycle of the pathogen. It has to be completely dependent on humans. If this was an infection or an agent that lived in both humans and animals or mosquitoes, eradication could be very difficult to achieve because it's hard to control what goes on with transmission in the animal kingdom. There also has to be consensus on the cost and benefits of pursuing the goal of eradicating a disease versus not pursuing it. And finally, since eradication means getting rid of the pathogen everywhere in the world, there needs to be a global societal and political support, or broad societal and political support, in order to consider pursuing the objective of eradication. Those are really the minimum criteria that need to be in place in order for an eradication initiative to be undertaken and to have a chance of being successful. This slide shows a table of past eradication initiatives. There have been 4 that have been conducted and concluded to date: yellow fever, yaws, malaria, and smallpox. And as I mentioned, only the smallpox eradication program was successful. For each disease, this table shows the different key criteria. Starting with the biological and technical feasibility, that criterion was really only met for smallpox. And the consensus on the cost and benefits existed only for malaria and smallpox, but not for yellow fever and yaws. And the same was true for broad political and societal support. Smallpox was the only pathogen for which all key criteria were met, and it was the only pathogen for which eradication has been successfully achieved. And on this slide, you can see a picture of Ali Mo-Ma'ali, who was the last known case of smallpox that occurred in Somalia in 1977. Now, those were examples of past disease eradication initiatives, but there are 2 disease eradication initiatives that are currently underway around the world. One is for polio, and the other one is for dracunculiasis, or guinea worm, which we're going to explore in detail as part of this example. In the Aylward paper, they provided details on some of the key disease eradication criteria in Table 2, shown here, and you can see how they compare for these 2 initiatives. Of course, one is a virus and one is a parasite, and they each meet various other criteria. You can also get a sense of the costs and benefits in the context of whether or not there's societal and political support. But one point I want to make about that, when it comes to societal and political support, this can change after a program gets underway. Specifically, it tends to be very high when the burden of disease or infection is high and is causing a lot of morbidity and mortality. But one challenge is that as these programs begin to get more and more successful at achieving their goals, there are many fewer cases and fewer people experiencing, the downside of some of these illnesses. So societal support can wane in those situations because people aren't affected as much as they used to be, and it's no longer perceived as the problem it was at the start of the eradication program. Yet, costs continue towards eradication. They have to continue, and they may not be going down, and they can sometimes even go up. The other thing that I want to point out here is that in the case of polio, the intervention being used to achieve eradication is the polio vaccine. There's a highly effective vaccine for polio. However, in the case of dracunculiasis or guinea worm, there's not a vaccine. And also, since the publication of this paper in your readings, it's come to light that dogs can get guinea worm disease, which could be a threat to the biological and technical feasibility of that program. But surveillance in the context of the guinea worm eradication is the last example that we're going to be covering, and you'll see the various components of the strategy to eradicate guinea worm and how that surveillance is a critical part of the strategy. When conducting surveillance in the context of disease eradication, unlike, for example, when we were monitoring the prevalence of HIV in antenatal clinics, when there were no prevention and treatment modalities available, In the context of an eradication program, the surveillance activities and the disease intervention activities are very closely linked, or sometimes even integrated, or maybe even can be considered one and the same. What that effectively means is that the people doing the surveillance are often also the same people who are doing the disease control or intervention activities. There also tends to be more of a focus on finding new cases in a very timely manner and on finding every single new case. This is in contrast to more conventional surveillance for disease control efforts. And finally, in the process of doing surveillance as part of a disease eradication initiative, it gathers critical information that's needed for monitoring and evaluation of the eradication program itself. Surveillance is the way. Surveillance is how you'll know whether or not the disease is in fact eradicated. So it really represents the bottom line. Dracunculiasis, or guinea worm disease, is caused by the ingestion of a parasite. It occurs in a seasonal way, and it has an incubation period of about 12 months. So with guinea worm, the time from infection to when symptoms begin to develop is about a year. In terms of symptoms and clinical presentation, an adult worm emerges through skin ulcers, usually in the lower extremities of the body. And when this happens, it can be very debilitating. It usually happens in adults, occurs in adults, but also can occur in children. There's no treatment available, but first aid is important for the individuals who are affected, and it also represents an opportunity for prevention, as we'll see. And it's important to provide first aid to the wound and to remove the guinea worm slowly over a period of days or weeks. Finally, people who get guinea worm disease don't develop immunity to subsequent exposures. The life cycle of the guinea worm parasite is largely dependent on humans. And if we start at the top left here in the circle, you can see a depiction of the parasite, the larva of which exist in a body of water inside something called a copepod, which is another living organism that harbors the parasite. What happens in the life cycle, moving over to the right, is that a human drinks water that is contaminated with the copepod and the guinea worm larva, and the larvae are released when the copepods pass through the gastric environment of the human. The larvae stay in the gut of the human where they mature and reproduce, which is stage 2 on the right of the diagram here. And then over time, these adult worms begin to mature in the lymph and migrate towards the surface of the skin when they begin to cause an itching sensation or even pain, usually, as I mentioned, in the lower extremities. And people with these symptoms then want to do something to relieve that pain and itching. And one thing they will want to do is put their feet in some water. And when they do that, the adult worm pushes its head through the skin and releases its larvae back into the water. And those larvae are then consumed by the copepods, and the cycle continues again. So that's the life cycle of guinea worm infection. And as you can see, at least according to this diagram, the life cycle is entirely dependent on humans. But as I mentioned, it has since been learned that dogs also can get guinea worm disease. So this is an example of an abscess that occurs when the adult worm is about to emerge from the host. And you can see a bubble here on the foot of this individual who is about to be treated with first aid. And here you can see where the adult worm has emerged, and there was about 3/4 of an inch of the worm sticking out of the wound. That's the head of the guinea worm. These worms can grow to be from 6 inches to 3 feet long, and it's really not clear how long a worm is when they first emerge. It's not clear how much is left inside the body. But it's really important not to pull it hard, because if it breaks, it can cause a very dramatic inflammatory response, which can be very debilitating and even cause a wound infection. And this slide shows an example of a guinea worm that's emerged from the upper extremity, slowly being pulled out with a set of tweezers. In fact, it can sometimes take days or weeks to slowly remove these worms without breaking them, because you definitely don't want to break them. Here's an example of a health worker that removed an entire guinea worm from someone who was infected. And you can see the little hook at the bottom of the worm, which is the tail end of the guinea worm. If you get that little hook, then you know you've gotten the whole guinea worm. If you don't, then it's likely broken with more remaining inside, which can cause some bad outcomes. One strategy that people and healthcare workers use to get the worm out without breaking it is to take a small twig and sort of roll the worm around it, pulling out a little bit each day with a small twist, so that over the course of a few weeks you can get the whole thing out. Guinea worm is such an ancient infection. It's been around for millennia, and some people say that this idea of twisting the worm slowly out of the wound on a stick is what's represented on the medical symbol, the caduceus. It may have its origins, in fact, in guinea worm. So what's the basis or rationale for embarking on eradication of guinea worm? As I mentioned, for a long time it was thought that humans were the only reservoir, but it recently became clear that dogs may carry guinea worm. But for the most part, humans are thought to be the main reservoir, which allows you to interrupt transmission by changing human behavior. As we'll see, there are many effective interventions to eliminate guinea worm transmission, and they often have secondary benefits, such as providing clean water. The Carter Center and UNICEF and the World Health Organization have been the organizations that have been leading the efforts towards guinea worm eradication. This slide shows some of the data on the reported cases of guinea worm disease by year across the whole world. In 1986, there were an estimated 3.5 million cases of guinea worm documented to have occurred, and over time, though, the eradication efforts have brought these numbers down substantially, such that by 1995, there were fewer than 100,000 cases reported. And this slide shows the situation in 1999. The panel on the left highlights that guinea worm cases as a result of eradication efforts were really limited to areas of the world that included Africa, the Arabian Peninsula, and Afghanistan. And more progress was made between then and 2010. And looking at the map on the lower right, about 1,800 cases of guinea worm were estimated to have occurred worldwide, and these were limited to just 4 countries in Africa. So how was such incredible progress achieved? What were some of the strategies used to prevent and control guinea worm as part of eradication efforts? It's a combination of things thought to be effective at preventing guinea worm spread and transmission, including health education, which is about telling people how to prevent guinea worm. It's about disease surveillance, looking for cases and then targeting prevention and control strategies where those cases are occurring. First aid can actually prevent onward transmission of guinea worm, and provision of safe sources of drinking water. Sometimes you can dig wells, for example, so that people aren't getting their drinking water from surface water like ponds. But this isn't always possible. And in those cases, you could provide crude water filters that filter out the copepods I mentioned that carry the guinea worm larvae. And finally, treating some of the ponds with pesticides at low concentrations has been another strategy that's been used to prevent guinea worm. So this is an example of a health education approach that you might come across in an area that was endemic for guinea worm. It shows a picture of a woman carrying a large barrel down to the pond to fill for drinking. And there are 2 red circles, one on her arm and one on her foot, indicating that she has guinea worm. And the woman behind her is saying, "Wait a minute, don't go in the water when you have a guinea worm." I'm not exactly sure how she could see the guinea worms from that distance, but that's perhaps besides the point. The poster is about trying to raise awareness and trying to educate people about the importance of not going into the water when you have a guinea worm, because it can contaminate the water and cause further spread when people drink it. So as you can imagine, in order to successfully eradicate any disease or pathogen, you really need to get down to a very local level. And I'm going to present some slides from an example of guinea worm eradication activities that were happening in a local government area, Ohaukwu LGA in Ebonyi state of Nigeria. So this is an area that had about 130,000 people living in about 23,000 households. It was very rural and without running water or electricity in households. So the drinking water came from ponds and streams and from harvesting rainwater. And for a long time, tribal clashes in the area really prevented safe access for health workers to go in and out of the area to work on guinea worm eradication. But those clashes and conflicts ended around March of 2000. At that time, Ohaukwu LGA was actually the most endemic local government area in Nigeria for guinea worm. And in the year 2000, for the first 9 months, for example, there were over 1,000 guinea worm cases reported. And so this small area was a major focus for guinea worm eradication efforts in Nigeria in the year 2000. And that was the time that I was invited by CDC and WHO to go there to provide some surveillance-related assistance and support to the Carter Center, which was leading guinea worm eradication efforts in Nigeria at the time. So this is a picture of a pond in Ohaukwu where many people would typically go to fetch drinking water, and you can see a person who's leaning over and getting some water out of the pond. The branch that's sitting there where people tend to go fill their water was put there intentionally and specifically to prevent people from wading into the pond to fill their water buckets and containers. So I like to think of it as a real world example of a structural intervention. And here's another example of some of the signs that you might see. This one was near a pond that says, notice, nobody is permitted to use the pond for molding block or selling water in the market. Taking a bath around it is no longer permitted. You should not put your leg inside it. Failure to obey the above order will result in a fine of 1,000 naira, which was about $10, 1 carton of beer, 1 bottle of snuff, and a pound of kola nut. This is a very, very stiff penalty. And it's another example of a strategy that was being used to change behavior to be more aligned with efforts to eradicate guinea worm in the area. This is an example of someone using the crude filters that I mentioned to filter water that they got from a pond into a larger container. The filter's held in place on top here, and you slowly pour the water through it so that the copepods that have the guinea worm larvae inside them are prevented from going into the water that later gets drunk. Those are some examples of the local strategies used to drive down cases of guinea worm, but the key or the glue to all of them happening is shown here in this picture, and it's the village-based health worker, or VBHW. The village-based health worker is someone who's trained about all of these strategies, and they're also provided with a bike, a first aid kit, and a paper register to document and track cases of guinea worm for surveillance. Each VBHW is assigned a group of villages that they visit regularly, where they routinely do health education, distribution of filters, they administer first aid when they find cases, and they document and report those cases when they occur as part of surveillance efforts. So just to give you a sense of the process drawn out here on the schematic, if you start at the top left, this is what's supposed to happen when a guinea worm case occurs. Because of the relationships and health education that the village-based health worker has developed and done in villages, the people in each village, either the people who develop guinea worm or say their household members, will notify the village-based health worker about the possible case. The village-based health worker then goes to the village to verify the case of guinea worm. If it is a case, they would administer first aid, and they would also give health education to the individual and to the household, and maybe to some of the surrounding households. They would also look in the home to see if they had water filters available so that they could filter their water. Importantly, the village-based health worker would record information on each case in their register, which would be submitted as part of a monthly summary that goes in for tracking and surveillance. The other pathway into this flowchart, when there are not case notifications occurring, is that the village-based health worker is proactively going to households within each village to distribute filters and deliver health education about guinea worm. So even if no one's saying that there are cases happening, that's often a time when village-based health workers will nonetheless come across people that have guinea worm. So while they're talking, someone may say, hey, or they're doing health education, may say, hey, I had that, or I know someone who's had that. And when that happens, it is treated as a case notification, and the same process I described earlier then happens. The village-based health worker verifies the case and so forth. In both instances, the VBHW will notify a field supervisor who's supervising the work of multiple other VBHWs, and those supervisors will occasionally come to a village with the village-based health worker to help verify cases and to work on submitting these monthly summaries of all of the cases that have been found. And those monthly summaries, the data are cleaned, and as part of, after the data cleaning, they get entered into a tracking database. And then taking this process to scale, starting from the bottom of the schematic here, there are, of course, many village-based health workers working across all of the different villages in a given local government area. They report their cases to their field supervisors. These go to the person who's responsible for guinea worm eradication work of the entire local government area, which in turn goes to the state level of a Bonyu state. The other 35 states are also reporting, and they send their case information to the zonal level. Ultimately, cases get to the country level, represented here as Global 2000 Nigeria. And that information from the country level gets reported to the World Health Organization and the Carter Center, who, again, are the entities that are coordinating the guinea worm eradication efforts around the world. This is the trend in reported guinea worm cases in Nigeria, and the activities I described were taking place in 2000 when there were almost 8,000 reported cases across the country. Since then, the trend continued to decline, and in 2009, Nigeria recorded 0 cases of guinea worm for the first time in history. Indeed, the New York Times reported about the campaign to eradicate guinea worm in Nigeria and how it may have worked. It's showing here on the bottom right the woman who was thought to be the last person in Nigeria who had guinea worm. So these are some of the latest global data on guinea worm. It's getting very close. Between January and August of 2023, only 6 cases of guinea worm had been reported worldwide. And you can see the countries here. Some of them had 0 cases and they're still being certified as having 0 transmission. But it would appear that in 2023, guinea worm transmission is really limited only to Cameroon and Chad. Just to remind you, this is down from an estimated 3.5 million cases globally in 21 countries in 1986. So getting very close to eradication here. Just to circle back to the guinea worm eradication program, there are very few cases occurring, and in this context, when a country reports 0 cases, you need to be really sure that it's really 0 cases, and that means that intense surveillance must continue. It has to be correct, and you can't really back off on surveillance because you need to always be making sure that there are 0 cases occurring until the disease is eradicated, right? So, but this is an example of what I alluded to earlier when there's a program at a point where many stakeholders may argue for redirecting some resources away from guinea worm surveillance to other, perhaps, more pressing health priorities. It becomes a real challenge to eradication programs that are in their sort of last leg of their efforts. So just to make a few concluding remarks here, here are some of the important things that are often still lacking in public health surveillance in resource-limited settings. Often there's data available, but what's needed is more analysis, dissemination, and triangulation of the different data sources to be able to better inform some of the activities that are happening from a public health standpoint. Due to the weak or non-existent vital registration systems, there's often little or no information on the cause of death distribution in many settings, and especially not by age and sex. And very little information is available on chronic diseases and their risk factors, although we saw an example of how the recent Demographic and Health Survey in Kenya was attempting to capture some of this information. There's also limited information on some infectious diseases that remain important causes of morbidity and mortality, such as human papillomavirus and hepatitis B and C. Finally, often the data get analyzed at the national level or maybe even the provincial level, but Public health action really happens at the local level, as we've said, and so it's important for surveillance systems to be able to have that geographic resolution so that they can work at not just the national level, but at much lower levels to be able to inform public health efforts locally. We saw how the large sample size of the Kenya DHS enables county level estimates, which is an example of what's really needed. And remember the early example of how in New York City, on the left here, it's possible to reliably rank the leading causes of death by neighborhood. We're a long way off from being able to do something similar in most resource-limited settings, but this is a visualization from the Global Burden of Disease project at the Institute for Health Metrics and Evaluation, and they've used the data they have to try to rank causes of death at the country level. And I'm showing here what this data looks like for the sub-Saharan African region. So you can see, the numbers in each of these cell blocks for the countries on the top, going across the top, and the different causes of death going down on the left. Ranking DALYs, the number one cause of DALYs in many cases is neonatal disorders, and then followed by HIV/AIDS and diarrheal diseases. But remember from our session on vital registration that in resource-limited settings, a lot of the estimates of causes of death are really based on modeling and sampling and very scant data. So the accuracy of the cause of death information may not always permit a reliable ranking. But this nonetheless underscores that it's going to be critical for countries to invest in robust and reliable vital registration systems and other surveillance capacity. So that's the end of this lecture. I hope it gave you a sense of some of the challenges in conducting public health surveillance in low-income settings, as well as the great need for better surveillance, and also some of the opportunities that exist to improve surveillance outcomes in resource-limited settings. Hopefully, it's also helped help you connect the things that we've covered so far in the course around surveillance tools and methods, and how they can be leveraged to conduct disease surveillance and public health surveillance in resource-limited settings. Have a great week.